Chapter 23, Med-Surg, TIMBY, Caring for Clients with Infectious and Inflammatory Disorders of the Heart and Blood Vessels. Learning Objectives. 1. Identify 3 organisms that cause infectious conditions of the heart. 2. List 4 inflammatory conditions of the heart. 3. Describe treatment for inflammatory and infectious heart disorders. 4. Discuss the nursing management of clients with infectious or inflammatory heart disorders. Name 3 types of cardiomyopathy. Differentiate between Phlebitis and Thromboingitis Obliterans. List 3 interventions that reduce the risk of Phlebitis. Discuss the nursing management of clients with inflammatory disorders of peripheral blood vessels. Infectious and inflammatory disorders of the heart, rheumatic fever and rheumatic carditis. The Pathophysiology and Etiology. Rheumatic fever follows group A streptococcal infection. Rheumatic carditis is an inflammatory cardiac manifestation of rheumatic fever. Assessment findings: mild fever, rapid heart rate and abnormal rhythm, red spotty rash on trunk but disappears quickly and leaves irregular circles on skin, swollen joints, warm, red and painful joints, heart murmur, and pericardial friction rub. Diagnostic findings. No laboratory test is specific for the diagnosis of rheumatic fever. The results of lab tests such as an anti-strep olysin O titer, erythrocyte sedimentation rate ESR, and C-reactive protein CRP are elevated, indicating an inflammatory process involving the streptococcal organism. Specific cardiac tests such as electrocardiography and echocardiography may show structural changes in the valves, size of the heart, and the heart's ability to contract. Medical and surgical treatment. Intravenous IV antibiotics are given. Penicillin, such as amoxicillin, penicillin G, and penicillin V, is the drug of choice for treating a group A streptococci infection unless contraindicated because of an allergy. For clients who are allergic to the penicillin family of antibiotics, either antibiotics such as azithromycin, clarithromycin, or clindamycin may be prescribed. Cephalosporins such as cephalexin or cefadroxil may be prescribed if the client has not had a previous severe allergic reaction to penicillin. Bed rest may be indicated depending on the client's condition. Aspirin is used to control the formation of blood clots around heart valves. Non-steroidal drugs such as naproxen, Aleve, and steroids are used to suppress the inflammatory response. Concurrent treatment of rheumatic carditis depends on the extent of heart involvement. If minor, no treatment may be given. If heart failure or life-threatening arrhythmias occur, extensive treatment is necessary. Surgery may be required to treat constrictive pericarditis and damage to heart valves. The American Heart Association in 2016 simplified the guidelines for prophylactic antibiotic therapy before invasive procedures previously believed to predispose the body to bacteremia and reoccurrence of endocarditis. Prophylactic antibiotics are no longer recommended for those having procedures involving the reproductive, urinary, or GI tracts. Nursing management. The nurse administers prescribed drug therapy and monitors for therapeutic and adverse effects. He or she plans diversional activities that require minimal activity, such as reading and putting puzzles together, to reduce the work of the myocardium and counteract the boredom of bed rest. Focused cardiac assessments help to track the progression or improvement of heart involvement. Clients with a history of rheumatic fever are susceptible to infective endocarditis. Additional nursing management depends on assessment data. Myocarditis diagnosis. Although an echocardiography can reveal information about the heart that may be indicative of myocarditis, the most definitive diagnostic technique is myocardial biopsy. High-risk procedures for clients with a history of rheumatic carditis or infective endocarditis. Prophylactic antibiotic therapy is recommended before dental procedures for clients with a prosthetic heart valve, a history of endocarditis, congenital heart defects that have not been fully repaired, congenital heart defects repaired with prosthetic material for 6 months after the repair, and repaired congenital heart defects with residual defects. The clients with rheumatic carditis for nutrition. A full liquid diet is used in the initial treatment of rheumatic heart disease and is progressed as tolerated. Sodium is restricted if the client has edema or is treated with steroids. Anorexia and weight loss are common side effects of infections. Calories and protein should be increased as needed to replenish losses. Fever increases fluid requirements. Encourage small, frequent feedings to maximize intake. Infectious and inflammatory disorders of the heart continues. Infective endocarditis. Infective endocarditis, formerly called bacterial endocarditis, is inflammation of the inner layer of the heart tissues as a result of an infectious microorganism. Although clients with rheumatic carditis may develop endocarditis, it is initially considered an autoimmune response, not an infection, because no microorganism can be isolated from blood or other cultured specimens. Subsequent to the initial rheumatic carditis, however, the valvular changes increase the client's susceptibility to endocardial colonization by pathogens. In addition to clients who have recovered from rheumatic carditis, other susceptible clients include those who have non-rheumatic valve disease or artificial heart valves, repaired congenital heart defects, a prolapsed mitral valve, or hypertrophic cardiomyopathy, and IV drug users and immunosuppressed clients with central venous catheters. The prevalence of infective endocarditis among older adults has increased due in part to the increased number of prosthetic valve replacements and an increase in hospital-acquired bacteremia. Pathophysiology and Etiology. The microorganisms that cause infective endocarditis include bacteria and fungi. Streptococcus and Staphylococcus are the bacteria most frequently responsible for this disorder. They are found abundantly on the skin and mucous membranes of the mouth, nose, throat, and other cavities. Most pathogens find their way into the bloodstream through trauma caused by invasive procedures involving mucous membranes or other tissues that harbor microorganisms. Although anyone can contract endocarditis, clients with a history of rheumatic carditis are especially susceptible. Prolonged IV therapy, insertion of cardiac pacemakers, cardiac catheterization, tracheal intubation, cardiac surgery, genitourinary instrumentation, such as Foley catheters and cystoscopy, and IV drug abuse creates portals of entry for the causative microorganisms. Once the microorganisms migrate to the endocardial surface, they attach to the vegetations composed of fibrin and platelets surrounding the heart valves, the chordae, tendineae, and papillary muscles. The microorganisms bury themselves in the vegetative mass, making them difficult to destroy with natural defenses or antibiotic therapy. The cycle continues with layer upon layer of embedded microorganisms and fibrin platelet deposits. The endocardium on the left side of the heart is affected more often than the right. The mitral valve is the most common location of vegetations and microbial deposits. If the valve leaflets erode and slough, blood leaks between the heart chambers, diminishing the heart's efficiency as a pump. Heart failure often is a consequence. The vegetations can break off to form emboli, mobile masses of fibrin and clusters of platelets that circulate in the bloodstream. Emboli may occlude small blood vessels and interfere with an organ's blood supply. Assessment findings. Infective endocarditis can have an acute onset less than 1 week from a previously healthy state. The client presents with fever, chills, muscle aches in the lower back and thighs, and joint pain. Subacute infections progress more insidiously over weeks to months with more vague manifestations such as headache, malaise, fatigue, and sleep disturbances. As the condition advances, purplish, painful nodules called Osler nodes, OSLER nodes, may appear on the pads of the fingers and toes. Black longitudinal lines called splinter hemorrhages can be seen in the nails. There may be small, painless, red-blue macular lesions known as Janeway lesions on the palms of the hands and soles of the feet. Roth spots, R-O-T-H, apostrophe S, Roth spots, white areas in the retina surrounded by areas of hemorrhage may be detected. The spleen may be enlarged and tenderness may be noted on abdominal palpation. A heart murmur may be present from malfunctioning valves. Petechiae, tiny reddish hemorrhagic spots on the skin and mucous membranes, are the signs of embolization. Pronounced weakness, anorexia, and weight loss are common. Symptoms can change suddenly if embolization or heart failure occurs. Emboli to the brain cause cerebrovascular accidents. Emboli to the kidneys cause flank pain and renal failure. Pulmonary emboli result in sudden chest pain and dyspnea. Clients with heart failure present with dyspnea, hypotension, and peripheral or pulmonary edema. Question: which of the following histories of a client would relate to a diagnosis of bacterial endocarditis? A. Previous heart catheterization. B. Strep throat 4 weeks earlier. C. Open reduction and internal fixation of the left hip last year. Or D. Smokes 2 packs of cigarettes a day. And the answer is strep throat 4 weeks earlier. The rationale: bacterial endocarditis is generally associated with an upper respiratory infection caused by the Streptococcus bacteria. Diagnostic findings: anemia, leukocytosis, blood cultures, transesophageal echocardiography and EKG, medical and surgical management, high doses of antibiotic IV therapy, bed rest, and valve replacement, nursing management, limit activity and assess for changes in weight, pulse rate, and rhythm, and administer antibiotics. Diagnostic findings review: anemia and slight leukocytosis are common findings. A series of 3 blood cultures collected over 1 to 24 hours usually identifies the microorganisms circulating in the blood. Some culture specimens require incubation for 3 weeks or more to identify accurately the infecting species. Occasionally, the vegetations can also be cultured. Transesophageal echocardiography is more likely than transthoracic echocardiography to reveal the vegetations, altered valvular function, and impaired pumping quality of the ventricles. EKGs may reveal abnormalities in heart rhythm if the vegetations involve a valve close to conduction tissue. Medical and surgical management: high doses of an IV antibiotic to which the organism is susceptible are prescribed initially. Drug therapy table 23.1 on page 384 in TIMBY. Antibiotic therapy extends at least 2 to 6 weeks. It is resumed if the infection recurs after discontinuation of the drug. Bed rest is ordered initially when the client begins to improve. Bathroom privileges and increased inactivity are allowed. If a heart valve has been severely damaged and drug therapy does not adequately support the heart and failure, valve replacement may be necessary. Nursing management: many clients cannot appreciate the danger of the disease without seeing external signs of the damage. The nurse gently but firmly reminds the client to limit activity. The nurse continually assesses for changes in weight, pulse rate, and rhythm, noting and reporting new symptoms. The nurse administers prescribed antibiotics around the clock to sustain therapeutic blood levels of the medication at all times. He or she informs clients that periodic antibiotic therapy is a lifelong necessity because they will be vulnerable to the disease for the rest of their life. Myocarditis. Pathophysiology and Etiology. Myocarditis is an inflammation of the myocardium, the muscle layer of the heart. A viral, bacterial, fungal, or parasitic infection causes most cases. Of viral origin is most common in the United States. The usual viral agents are Coxsackie viruses A and B, influenza A and B viruses, measles, adenovirus, mumps, rubella, rubeola, Epstein-Barr virus, and cytomegalovirus. The myocardium also can become inflamed from the toxins of microorganisms, chronic alcohol and cocaine abuse, radiation therapy, or autoimmune disorders. Clients with bulimia who use syrup of ipecac to facilitate purging can develop myocardial damage similar to viral myocarditis. Whatever the damaging agent, an inflammatory response causes the cardiac muscle tissue to swell, which interferes with the myocardium's ability to stretch and recoil. Cardiac output is reduced and blood circulation is impaired, predisposing the client to heart failure. The myocardium becomes ischemic from a reduced supply of oxygenated blood, creating a potential for tachycardia and arrhythmias. Cardiomyopathy, evidenced as atypical changes in the myocardial wall, may develop as a complication of myocarditis and other disorders. Signs and symptoms. Clients may complain of sharp stabbing or squeezing chest discomfort that resembles an MI, a myocardial infarction. However, sitting up relieves the pain. Accompanying manifestations include a low-grade fever, tachycardia, arrhythmias, dyspnea, malaise, fatigue, and anorexia. The skin may be pale or cyanotic. If the heart's pumping activity becomes impaired, neck vein distension, ascites, which is great swelling in the abdomen, and peripheral edema may be noted, indicating right-sided heart failure. Crackles may be heard in the lungs if the left side fails. An S3 galloping rhythm or a pericardial friction rub may be heard. Diagnostic findings. Serum electrolyte levels and thyroid function studies help rule out other causes for the client's symptoms. The white blood cell count is slightly elevated. C-reactive protein, a nonspecific antigen antibody test, is elevated in inflammatory conditions. Cardiac isoenzyme levels are elevated, and EKG results may be abnormal. Chest radiography shows overall heart enlargement and fluid infiltration in the lungs. Echocardiography demonstrates structural and functional abnormalities in the ventricles, such as impaired motion of the ventricle wall and reduced ejection of blood from the heart. Radionuclide studies reveal areas where the myocardial wall is enlarged, thickened, or scarred. A myocardial biopsy may be done to obtain a definitive diagnosis. Medical and surgical management. Management aims at treating the underlying cause and preventing complications. Antibiotics are prescribed if the infecting microorganism is bacterial. Bed rest, a sodium-restricted diet, and cardiotonic drugs such as digitalis and related drugs are prescribed to prevent or treat heart failure. In severe cases of cardiomyopathy, a heart transplant is necessary. Nursing management. The nurse monitors the client's cardiopulmonary status to assess for possible complications such as heart failure or arrhythmias. Assessment includes vital signs, daily weights, intake and output, heart and lung sounds, pulse ox measurements, and determination of the presence of dependent edema. The nurse also maintains the client on bed rest to reduce cardiac workload and promote healing. If the client has a fever, the nurse administers a prescribed antipyretic along with independent nursing measures such as minimizing layers of bed linens, promoting air circulation and evaporation of perspiration, and offering oral fluids. Administering supplemental oxygen relieves tachycardia that may develop from hypoxemia. The nurse elevates the client's head to promote maximal breathing potential and uses a bedside cardiac monitor or telemetry unit to assess heart rhythm. The nurse uses cardiac rhythm analysis to determine if and when antiarrhythmic medications are necessary or the client's response to their use. Category and common generic brand drugs Agents used to treat endocarditis. Penicillin family, which includes ampicillin, penicillin G, and nafcillin, kill susceptible microorganisms by interfering with bacterial cell wall development. Common side effects: glossitis, stomatitis, gastritis, furry tongue, nausea, vomiting, diarrhea, rash, fever, pain at injection site. Safety and warnings for nurses: monitor for anaphylaxis reaction and monitor IV infusion for phlebitis. Phlebitis is like a reddened irritation vein, and you can see it. It gets red on the arm. Cephalosporins are another treatment. Ceftriaxone, which is Rocephin, kills susceptible microorganisms by interfering with bacterial cell wall development, so it's similar to the penicillin family. Common side effects: nausea, vomiting, diarrhea, headache. May show allergy if allergic to penicillin. Avoid alcohol intake and monitor for kidney toxicity. Vancomycin, such as vancomycin, kills susceptible gram-positive microorganisms not responding to treatments with other antibiotics. Nausea, chills, fever, urticaria, which is itching. Monitor for ototoxicity, which is ear problems, and nephrotoxicity. Increased bleeding risk when client is on anticoagulant therapy. Hyposensitivity alert with rapid IV infusion. So you could have low blood pressure from that one. Aminoglycoside, such as gentamicin, kills susceptible gram-negative microorganisms by interfering with protein synthesis. Side effects: dizziness, vertigo, nausea, vomiting. But monitor for ototoxicity again and nephrotoxicity. Do not use if client has Parkinson's disease. Daptomycin, and another name is cubicin, Cubicin, kills Staph aureus microorganisms by interfering with protein synthesis. Nausea, diarrhea, constipation, rash, vein irritation. Monitor cardiac enzymes if taken with statins. Increased bleeding risk when client is on anticoagulant therapy. And then rifampin, otherwise the brand name would be Rifadin, kills susceptible microorganisms by inhibiting RNA polymerase activity in bacterial cell. Headache, drowsiness, fatigue, dizziness, heartburn, epigastric distress. Must be taken on an empty stomach. Will turn body fluids orange. Monitor liver enzymes and monitor for pancreas suppression, pancytopenia, pancytopenia. Cardiomyopathy is a chronic condition characterized by structural changes in the heart muscle. There are three major types: dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. The International Society and Federation of Cardiology and the World Health Organization added two other types of cardiomyopathy to the list: arrhythmogenic right ventricular cardiomyopathy, which is inherited, and peripartum cardiomyopathy, which develops in women shortly before or after giving birth. The following discussion focuses on dilated, hypertrophic, and restrictive cardiomyopathies. Pathophysiology and Etiology. In some cases, cardiomyopathy develops without explanation. In others, cardiomyopathy accompanies or follows another medical problem, such as myocarditis, connective tissue disorders such as systemic lupus erythematosus, muscular dystrophy, chronic alcoholism, or cancer chemotherapy. Regardless of the cause, the heart muscle loses its ability to pump blood efficiently. When a client's medical history includes disorders that are bacterial or viral in origin, a family history of early cardiac deaths, or any of several other conditions that correlate with heart involvement, the possibility of cardiomyopathy is considered. Some affected clients remain in stable condition for a long period before they develop disabling symptoms. Others may be unaware of their condition until they experience a potentially fatal cardiac event, such as a sudden dysrhythmia or heart failure. Signs and symptoms. The manifestations of cardiomyopathy vary slightly according to the type that develops. Dilated cardiomyopathy, the most common type, is accompanied by dyspnea on exertion and when lying down. The client experiences fatigue and leg swelling and may have palpitations and chest pain. Hypertrophic cardiomyopathy is associated with syncope, which is a sudden loss of consciousness or fainting, or near syncopal episodes, which the client may describe as graying out. Clients may also feel fatigued, become short of breath, and develop chest pain. Many are asymptomatic, however, and the disorder is not discovered until the affected person becomes acutely ill after strenuous exercise or dies. Restrictive cardiomyopathy, which is the least common type in the U.S., but more common in tropical locales of Africa, India, South and Central America, and Asia, has symptoms of exertional dyspnea, dependent edema in the legs, ascites, which is fluid in the abdomen, and hepatomegaly, which is enlarged liver. A heart murmur, which is an atypical heart sound, may be the first abnormal sign detected in any type. Forceful heart contractions may be palpated over the left chest wall. Types of cardiomyopathy: dilated. The causes are viral, myocarditis, autoimmune responses, chemicals such as chronic alcohol ingestion. The description of dilated cardiomyopathy is the cavity of the heart is stretched or dilated. The drug treatment to minimize symptoms and prevent complications is the treatment abstinence from alcohol, salt restriction, weight loss, and possible heart transplantation. Hypertrophic cardiomyopathy is from heredity. The muscles of the left ventricle and septum thickens, causing heart enlargement. Drug therapy to reduce heart rate and force of contraction. Antiarrhythmic drugs, these are the treatments. Artificial pacemaker, alcohol ablation, in other words, stop drinking, injection of alcohol into an artery supplying the extra tissue to destroy excess heart muscle is currently experimental. Ventriculomyotomy is a surgical procedure to reduce muscle tissue because it's too big. Restrictive cardiomyopathy causes are deposits of amyloid scleroderma, a connective tissue disorder, granulomatosis tumors, hematochromatosis, iron stores in tissue, and scar tissue that forms after a myocardial infarction, or otherwise known as a heart attack. Description is the heart muscle stiffens, which interferes with its ability to stretch and fill with blood. There is no specific treatment. Drugs such as diuretics and antihypertensives are used to control symptoms. Diagnostic findings include chest x-rays, EKGs, echocardiograms, cardiac MRIs, and cardiac caths. Medical and surgical management: diuretics, digitalis, antihypertensives, antidysrhythmic, anticoagulants, corticosteroids, and dietary sodium restriction. Surgical intervention: pacemakers, defibrillators, ventriculomyectomy, and a heart transplant. Nursing management is medical and family history, physical exam, vital signs, lung sounds, heart sounds, edema, abdominal enlargement, SpO2, which is pulse ox, cardiac monitoring, O2 therapy, and emotional support for the patient. Pericarditis. Pericarditis is inflammation of the pericardium. It can be a primary condition developing independently of any other condition, or a secondary condition developing because of something else. The inflammation can occur with or without effusion, the accumulation of fluid between two layers of tissue. Pathophysiology and Etiology. Pericarditis usually is secondary to endocarditis, myocarditis, chest trauma, or MI, heart attack, or develops after cardiac surgery. Other contributing causes include tuberculosis, malignant tumors, uremia, and connective tissue disorders. When the pericardial cells become inflamed, their membranes become more permeable and intracellular fluid leaks into the interstitial spaces. The exudate or effusion can be serous, S-E-R-O-U-S, resembling clear serum, fibrinous like thick congealed liquid, purulent containing pus, or sanguinous containing blood. Pericardial fluid accumulation results in cardiac tamponade, acute compression of the heart. The pericardial fluid occupies space the heart needs to accommodate filling with blood. The impaired filling is reflected by a condition called pulsus paradoxus or paradoxical pulse. Pulsus paradoxus is a difference of 10 millimeters mercury or more between the first carot cough sound heralding systolic blood pressure heard during expiration and the first that is heard during inspiration. Normally, the difference between the two is 4 to 5 millimeters mercury. The technique for detecting pulsus paradoxus is described in Nursing Guidelines 23.1. Pulsus paradoxus develops because of a greater reduction in the volume capacity of the left ventricle during inspiration, combined with an impaired ability of the left ventricle to expand because of the rigid pericardium. The smaller capacity reduces the stroke volume from the left ventricle. As cardiac tamponade progresses, stroke volume is diminished, cardiac output is compromised, and death may result if the condition continues uncorrected. Signs and symptoms. The typical signs and symptoms that accompany an inflammatory response, such as fever and malaise, are present. The client is dyspneic or complains of heaviness in the chest. One chief characteristic is precordial pain, pain in the anterior chest overlying the heart. It may be slight or severe and can be mistaken for esophagitis, indigestion, pleurisy, or heart attack, MI. Moving and breathing deeply worsens the pain. Sitting upright and leaning forward relieve it. In contrast, the pain of acute MI remains unchanged regardless of position, movement, or breathing. A pericardial friction rub, a scratchy, high-pitched sound, is a diagnostic sign. Heart sounds are difficult to hear because the accumulating fluid muffles them. Respiratory symptoms occur as the enlarged heart crowds the airway passages and lung tissue, and respirations become rapid and labored. Hypotension is severe, and pulse quality is weak. Assessment of pulsus paradoxus. Advise the client to breathe normally through the assessment. Inflate the blood pressure cuff to 20 millimeters mercury above systolic pressure. Deflate the cuff slowly, noting that sounds are audible during expiration, but not inspiration. Note when the first blood pressure sound or carot cough is heard. Continue to deflate the cuff until the blood pressure sounds are heard during both inspiration and expiration. Measure the difference in millimeters of mercury between the first blood pressure sound heard during expiration and the first blood pressure sound heard during both inspiration and expiration. Diagnostic findings. The ST segment of the EKG is elevated, but cardiac isoenzymes are normal. The heart may appear enlarged on chest X-ray. EKGs demonstrate a wide gap between the pericardium and epicardium, indicating that the space is filled with fluid. Hemodynamic monitoring values are abnormal. Pericardial fluid may be cultured, but if the cause of the pericarditis is non-bacterial, the test results often are non-diagnostic. Because of the inflammatory nature of pericarditis, the white blood cell count and ESR often are elevated. Medical and surgical management. An MI must be ruled out. Treatment of pericarditis depends on the underlying cause. Rest, analgesics, antipyretics, nonsteroid anti-inflammatory drugs called NSAIDs, and sometimes corticosteroids are prescribed. Pericardial encentesis, needle aspiration of fluid from between the visceral and parietal pericardium, may be necessary when cardiac output is severely reduced. A small drainage catheter can be left in place. Needle aspiration is hazardous because the needle can puncture the myocardium, a branch of a coronary artery, or the pleura. When pericardiocentesis and catheter drainage are inadequate, a pericardiostomy, a surgical opening or window, is made in the pericardium to allow the fluid to drain. Surgical treatment for constrictive pericarditis involves removing the pericardium, pericardiectomy, or removing the surface layer of the pericardium, decortication, to allow more adequate filling and contraction of the heart chambers. Nursing process for the client with pericarditis. Assessment. Ask the client about the incidence and nature of the pain and what worsens or relieves it. Assess for pericardial friction rubs by auscultating heart sounds while the client briefly holds his or her breath. A pericardial friction rub does not disappear when the breath is held. Note additional signs and symptoms that may further suggest cardiac tamponade and decreased cardiac output, such as muffled heart sounds, pulsus paradoxus, jugular neck vein distension, persistent cough, dyspnea, fainting or near fainting, anxiety, and changes in pulmonary function. Assess pain status as often as vital signs. Pain is considered the fifth vital sign. Whenever pain exists, the nurse must implement the interventions targeted for its relief. Assist client to a position of comfort, such as sitting upright and leaning forward. Only the outer layer of the lower parietal pericardium is sensitive to pain. Some of the pain of pericarditis results from inflammation of surrounding structures. Sitting up and leaning forward positions the stretched pericardium away from the pleura, which relieves discomfort. Administer anti-inflammatory drugs and analgesics as prescribed. The purpose: reduce inflammation and pain transmission, promotes comfort. Reassure the client that pericardial pain does not indicate an MI. Anxiety increases heart rate and force of heart contractions, which contributes to pain. Clarifying the reality and significance of the pain may reduce the workload of the heart and acuity of discomfort. Monitor vital signs every 4 hours and as needed. Hypotension and tachycardia are signs of decreased cardiac output. Hypo tension. Measure urine output every 4 hours unless output is greater than 35 milliliters per hour. The kidneys cannot form urine when the renal arterial blood supply is reduced, secondary to decreased cardiac output. An output of at least 35 milliliters per hour is necessary to eliminate nitrogen waste and other toxic substances. Monitor for cardiac arrhythmias. Hypoxemia is a leading cause of arrhythmias. Inadequate cardiac output creates potential for myocardial ischemia and disturbances in electrical conduction. Assess orientation. Confusion and disorientation are signs of compromised cerebral arterial blood flow secondary to decreased cardiac output. Instruct the client to report chest pain. It is a consequence of inadequate blood supply to the myocardium. Maintain bed rest. Activity increases the demand for myocardial oxygenation, which depends on cardiac output. Administer supplemental oxygen as prescribed. Giving more than 20% oxygen that is present in room air helps to reduce hypoxemia that results from inadequate cardiac output. Provide 6 small meals a day. Avoid gas-forming foods. Abdominal distension crowds the thoracic cavity and compresses the space the heart needs to fill with blood and the lungs need to fill with air. Restrict caffeine and sodium. Caffeine increases heart rate and sodium increases circulating blood volume, both of which increase myocardial work and the need for cardiac output. Collaborate with the physician regarding a stool softener. Bearing down during bowel movements interferes with cardiac filling and output. Stool softeners often promote ease of eliminating stool. Administer prescribed medications such as sedatives, anti-anxiety meds, vasodilators, diuretics, and antiarrhythmics. Reducing anxiety, keeping the client calm and quiet, reducing blood pressure and volume, and facilitating normal heart conduction helps avoid exceeding the heart's ability to eject an adequate cardiac output. Monitor for tachycardia, pulsus paradoxus, neck vein distension, cough, syncope, and muffled heart sounds every 4 hours. This is for cardiac tamponade. This cluster of signs and symptoms accompanies cardiac tamponade, which interferes with filling volumes. Blood that cannot enter the heart accumulates in both venous and pulmonary circulation. Have an emergency pericarditis tray available. Removing fluid from between the parietal and visceral pericardium relieves cardiac tamponade. Reinforce the physician's explanation of pericardiocentesis and witness the client's signature on a consent form. This is an invasive procedure that requires informed consent from the client if he or she is alert or from whoever has durable power of attorney. Obtain baseline vitals before pericardiocentesis. They are used for comparison during and after the procedure. Measure, describe, and record the amount of pericardial fluid removed. Documentation is a record of the client's care and outcomes of treatment. Label all specimens for laboratory analysis and send them promptly to the lab. Accurate information and prompt delivery facilitates diagnosis and appropriate treatment. Cover the site of the pericardiocentesis with a sterile dressing and inspect the dressing for bleeding or leaking fluid. Compromising the skin and underlying tissue creates a potential for blood and fluid loss, as well as an entry site for microorganisms. Reinforce the dressing if it becomes moist. Moist gauze acts as a wick and pulls microorganisms from the skin surface toward the puncture wound and deeper tissue. Continue to monitor vital signs until they are stable. Continued assessments help identify complications so that they can be treated early or validate a favorable response to therapy. Reviewing interventions again for pericarditis, monitor for tachycardia, pulsus paradoxus, neck vein distension, cough, syncope, and muffled sounds every 4 hours. Cover the site of the pericardiocentesis with a sterile dressing and inspect the dressing for bleeding or leaking fluid. Compromised skin and underlying tissue creates a potential for blood and fluid loss, as well as an entry site for microorganisms. Evaluation. Patient states pain is relieved, vital signs are stable, normal cardiac rhythm, and cardiac tamponade is managed. Question. A patient with pericarditis has been admitted to the cardiac intensive care unit. The nurse caring for the patient knows that the most common clinical assessment of pericarditis is what? Select all that apply. Is it A, diaphoresis, which is heavy sweating, B, chest pain, C, elevated cardiac enzymes, D, friction rubs, or E, all of the above? The answer should be E, all of the above. The signs and symptoms of the inflammatory disorders of the heart, including all the following. Other symptoms include arrhythmias, heart murmurs, and cardiac enlargement. Inflammatory disorders of the peripheral blood vessels. Thrombophlebitis. Thrombophlebitis is an inflammation of a vein accompanied by a clot or thrombus formation. Although clots can form in any blood vessel, the veins deep in the lower extremities are most commonly affected. In such cases, the condition is referred to as deep vein thrombosis, abbreviated DVT. Thrombi that form in or above the popliteal vein of the leg are at high risk for migration toward the pulmonary circulation. These cases are referred to as Pulmonary Embolus, PE. Pathophysiology and Etiology. When the inner lining of a vein is irritated or injured, platelets clump together, forming a clot. The clot interferes with blood flow, causing congestion of venous blood distal to the blood clot. Sometimes collateral vessels recirculate the blood blocked by the clot. Accumulated waste products in the blocked vessel irritate the vein wall, initiating an inflammatory response. The increased permeability of cells and the convergence of leukocytes and lymphocytes cause the area to swell, redden, and feel warm and tender. Medications that can irritate vessels are called vesicants. And this is vesicants pertaining to IV meds. Ask the clinical pharmacologist whether the drug is a vesicant infusion whenever you are about to inject a drug if you are not familiar with its properties. The development of a PE, pulmonary embolism, may complicate thrombophlebitis if the clot in the extremity becomes mobile and moves in the venous circulation to the lungs. Despite appropriate and successful treatment of thrombophlebitis, some clients experience a vascular complication referred to as post-phlebitic syndrome for up to 5 years after the initial episode. For example, valvular impairment in the affected vein may follow the original thrombotic event. The incompetent valves are less efficient at returning venous blood to the heart. When venous pressure increases because of pooled blood, some fluid leaks from capillaries into subcutaneous tissues, causing leg ulcers. Venous stasis, slowed circulation, altered blood coagulation, and trauma to the vein, referred to as Virchow's triad, VIRCHOW, Virchow's triad, This predisposes clients to thrombosis and thrombophlebitis, those three things: slowed circulation of the veins, altered blood coagulation, and trauma to the vein. Factors that contribute to clot formation include inactivity, reduced cardiac output, compression of the veins in the pelvis or legs, and injury. Some IV drugs and chemicals also irritate the vein. Thrombi are prone to form in an arm, subclavian, or jugular veins that have IV cannulas in them for extended use especially. Older adults with heart and blood vessel disease are susceptible to thrombophlebitis because of impaired mobility, reduced activity, and compromised circulation. Risk for clot formation is increased among women who take oral contraceptives, although the exact trigger is not known. Women who take oral contraceptives and smoke are at even higher risk. Assessments. Signs and symptoms. Clients with thrombophlebitis often complain of discomfort such as calf pain in the affected extremity. Heat, redness, and swelling develop along the length of the affected vein. Capillary refill takes less than 2 seconds because of venous congestion. The client often has fever, malaise, fatigue, and anorexia. Diagnostic findings include Doppler ultrasounds, venographies, impedance, plethysmographies, which are IPGs, medical and surgical management, ambulation, compression bandaging, anticoagulant therapy, continuous warm wet packs, surgical intervention, thromboectomy and ligation, nursing management, take a history of blood clots, risk factors, obesity, contraceptive use, Hohmann sign, pain or tenderness in calf, capillary refill, and PE, which is pulmonary embolism. Symptoms are chest pain and dyspnea. Thromboingitis Obliterans, called Buerger's disease, Buerger, Pathophysiology and Etiology. This is known as the thromboingitis obliterans is an inflammation of blood vessels associated with clot formation and fibrosis of the blood vessel wall. It affects primarily the small arteries and veins of the legs. It occasionally affects the arms. Pathophysiology and etiology, the cause, which is rare, is far more common in men than in women, predominantly among those who smoke cigarettes or use smokeless tobacco. The onset usually is during young adulthood. The affected arteries are prone to spasms that constrict the arterial lumen. Inflammatory lesions are found in isolated segments intermixed among healthy areas of the same vessel. The lesions occlude blood flow through the vessel during exercise and at rest. Skin and soft tissue cells experience degrees of hypoxia and anoxia. Some cells die. The necrotic dead tissues slough, forming ulcerations. The extent may be so severe that gangrene results. Thrombophlebitis may also be present. Assessment findings. The client notes that one or both feet are always cold and may report numbness, burning, and tingling in some areas of the feet. Intermittent claudication, leg cramps after exercise, is a common symptom. Pain occurs at rest when circulation has been seriously impaired. The symptoms usually fluctuate in severity. Remissions often follow attacks of acute distress. Cyanosis and redness of the feet and legs sometimes occur. The skin frequently is a mottled purplish red and appears thin and shiny with sparse hair growth. Shallow, dry leg ulcers in various stages of healing may be seen. Black, gangrenous areas may develop on the toes and heels. The nails are thick. Peripheral pulses are present during rest but diminish or disappear with activity. Capillary refill is prolonged. Doppler ultrasound, IPG, and angiography help to evaluate the location and extent of vessel destruction. Medical and surgical management. Tobacco in any form is restricted. Buerger-Allen exercises are ordered to stimulate and promote collateral circulation. Walking and active foot exercises are allowed as long as they do not cause pain. Analgesics are prescribed to ease discomfort. If leg ulcers develop, treatment may include moist dressings that are changed when the gauze becomes damp. and topical antiseptics or antibiotic ointments. Sympathectomy, the surgical interruption or suppression of some portion of the sympathetic nerve pathway, is performed to relieve vasospasm. If ulcerations occur, wound debridement, removal of necrotic tissue, and skin grafting may be required. If circulation becomes so impaired that gangrene results, amputation is necessary. Nursing management. The nurse takes a thorough history, which includes a smoking history and a review of symptoms and how long they have been present. The history also includes the client's description of the type and degree of pain and factors that increase or decrease it. The nurse examines the affected area for redness, swelling, and other color changes such as cyanosis and mottling. He or she inspects the nails and skin for changes and notes the skin temperature above and below the affected area. The nurse also monitors the presence and quality of peripheral pulses and assesses capillary refill time. The nurse instructs and supervises the client about Berger-Allen leg exercises. When the client is not performing exercises, he or she must keep the legs horizontal or dependent. Teaching the Berger-Allen exercises. Lie flat in bed with both legs elevated above the level of the heart for 2 or 3 minutes. Sit on the edge of the bed with legs dependent or lower than the head for 3 minutes. Exercise the feet and toes by moving them up, down, inward, and outward. Return to the first position and hold it for about 5 minutes. Repeat the exercises several times during one exercise period and perform them periodically throughout the day. When the client is not performing exercises, he or she must keep the legs horizontal or dependent. Elevating the legs increases ischemia and therefore contributes to pain. The nurse carries out meticulous wound care if leg or foot ulcers exist. Hospitalization for acute problems or complications may occur, but the client must carry out most care at home. The nurse teaches the client self-care techniques and stresses the importance of smoking cessation and performing prescribed exercises consistently. Self-care involves avoiding caffeine, tobacco, and over-the-counter drugs that cause vasoconstriction, such as nasal decongestants, and inspecting the fingernails, toenails, and skin on the arms and legs daily. The nurse teaches the client to clean the arms and legs daily, prevent trauma to the extremities, wear properly fitting shoes and socks, and avoid prolonged exposure to the cold. When cold weather is unavoidable, the nurse advises the client to wear thick socks or insulated boots and gloves to protect against exposure to low temperatures. A nurse is educating the client on the causes of Berger's disease. Which of the following would indicate a client's understanding of the disease process? A. Large arteries of the legs are primarily affected. B. The condition has no familial tendencies. C. The condition is associated with smoking. Or D. The disease causes pain with activity. The answer is the condition is associated with smoking. The rationale: Berger's disease is an inflammatory process affecting primarily the medium-sized arteries or veins of the legs and causes occlusion of circulation. Smoking, which causes vasoconstriction, can exacerbate the disease process, which means make it worse. This is the end of the slideshow.